Good morning, everyone. Everyone does not have the benefit of being tall as Dan, so I'm going to lower the podium a little bit. I feel like I'm peering over the monitors. So, welcome to Atlanta and welcome to CDC. I appreciate you bearing with the humidity and the traffic in order to get here. We didn't anticipate the congestion in the front, so we had to make some modifications to our agenda. I think we're still on task, though, honestly, which is great. Great. My name is Janita Bell. I'm the team lead for the long-term care facility component of NHSN. And you will hear a little bit from me and then my colleague, Dr. Nicola Thompson, before we dive into the training material. We just want to make sure that we optimize the time we have with you. We're very appreciative of the time and the resources that you expended being here with us. As such, we have a packed agenda, so we're just going to give you some background information to help establish the importance of reporting to NHSN, but also let you know about some other activities that we're engaged in order to supplement the data that we receive from NHSN. So today I'll talk about the burden of healthcare-associated infections in long-term care, or HAIs, in long-term care, challenges affecting nursing homes, also other healthcare settings in long-term care, strategies to overcome those challenges, why do surveillance, just kind of piggyback after Dr. Pollack's comments from earlier today, and give you a brief overview of the annual training so you know what to expect for the remainder of the week. So first, I'd like to start off by discussing nursing home infection burden estimates that are commonly cited in the literature. According to Strasbaugh and Joseph, there are 1.64 to 3.83 million infections annually in nursing homes. Herzig and her colleagues found that in the year 2013, there were 1.13 to 2.68 million infections. Now, when I put this slide together, I hesitated a little bit because it's almost like comparing apples and oranges. The first estimate is pretty much an incidence. It tells you what happens annually in nursing homes, where the second one is a prevalence. It tells you what has happened in the year 2013. But this is some of the best data that we have. And I apologize if you practice in a setting other than nursing homes. I don't have much information on that. But nursing homes pretty much is a good example to, discuss the topics that I'm going to share with you today. But I'm going to share a little bit of information about how they conducted the studies to derive these estimates. I promise I won't share too many details because I don't want to bore you to death at the very first top of the morning. But I think it's important to understand what the limitations are in these studies so that you will then also understand why it's so important for us to report into NHSN and participate in improving data. So Strasbaugh looked at 12 studies from the 1970s and the 1990s and estimated that there are 1.8 to 13.5 infections per 1,000 resident care days in long-term care facilities. Notice the term long-term care facilities. But they wanted to look at nursing homes. And so they extrapolated from that estimate and looked at incident rates for common infections in nursing homes, some of the usual suspects you might expect, like urinary tract infections and respiratory tract infections, and derived an estimate from those and determined that there are 0.98 to 7.38 million infections annually in nursing homes. Now, they published that data a while ago. After they had published that, there are other studies that came about that had better design and more representative facilities. And so they took the data from those studies and revised their estimates and determined that there are 1.64 to 3.83 million infections annually in nursing homes. Now, is anyone confused about what the methodology may have been in order to derive those estimates? Don't be shy. As you can see, my hand is also raised. The methodology that they used wasn't quite clear. But you gain more confidence in what they did when you look at their results. Here you can look on the left-hand side of the figure and you see that they looked at bacteremia, UTI, skin and soft tissue infections, gastroenteritis, and lower respiratory tract infections. And they determined an incident rate range, and that's what the dumbbells represent here on this slide. And they found that lower respiratory tract infections have the highest estimated incidence rate per 1,000 resident days, which is not too surprising. It's something you may expect on your own. Herzig and her colleagues, they looked at the minimum data set, or MDS 3.0, for 2013 quarter 4. They used routinely scheduled assessments, excluding admission assessments, because they wanted to make sure the infections they included in their estimate was nursing home onset and not present on admission, meaning that the person came in with an infection. And they didn't evaluate the MDS infection items they had available. such as multi-drug resistant organisms, pneumonia, septicemia, UTI, and wound infection. You notice that gastroenteritis is not included because they did not have that infection item available to them. They determined their prevalence using a 7-day look-back period, and for UTI, they use a 30-day look-back period. And here's what they found. They determined that in 2013, pneumonia and UTI were the most commonly reported infections among all resident assessments. So for example, among all those assessments, 2.1% included pneumonia during a 7-day look-back period, and 5.6% of the assessments included UTI for a 30-day look-back period. You notice I keep emphasizing the 7-day and the 30-day because the numbers look small. At first you look at it and you say, well, that's not too impressive. But if you figure the time in, the 7 days, 2.1% is pretty prevalent. So to add a little bit of icing to the cake, I included the Office of the Inspector General report that was published in 2014. And the Office of the Inspector General looked at adverse events in skilled nursing facilities among Medicare beneficiaries that were discharged during the month of August in 2011. And they determined that events related to infections were responsible for 26% in adverse events, with pneumonia, respiratory tract infections, surgical site infections, catheter-associated UTIs, and Clostridium difficile infection being some of the most common. Now, hopefully, while explaining these different studies, maybe you had some time to kind of think about what some of the limitations may be. And so here on this slide, I just give a brief overview. This may not be applicable to every study that I just described, but just some things that we need to consider. The estimates are based on a small number of residents, and that becomes important when you think about representativeness. You want to know whether or not these data are actually applicable to the residents that you see in your own healthcare facility. It also applies to the geographic location. I think we can all probably safely hypothesize that a facility in California may not be the same as a facility in Michigan. And therefore, the data that applies to a facility in California may not be applicable to you in Michigan. So again, we're talking about representativeness and ability to generalize the data to where you currently practice. Also, standard infection definitions are not used. I can pretty much guarantee that the definitions they use for the infections they reported data on differ between all three studies that I mentioned to you. Even among the Herzig study and the Office of the Inspector General report, although they use MDS data, if the year was different, the definition for the infection may have been different. That becomes important because over time, when you make comparisons, you want to know that you're counting the same thing. And also, you want to know what the trends of infection are over time. You don't know that when I provide you just a burden estimate. I mean, do you feel wiser now that I've given you some burden estimates about how to prevent infections in your facilities? Well, probably not, because several key questions haven't been answered, and that's the benefit of monitoring trends over time. You don't know how many new infections are occurring from the estimate I provided you. You don't know what rates of infections are problematic, whether the problem is worsening or is it getting better. So for me, in order to answer those questions, we have to have improved national data. It's needed to inform prevention. And I categorize those questions as to who, what, when, where, and how. For example, who's disproportionately affected and most at risk for any infection? What infection type is the most problematic? Where should we focus our efforts? Is the problem new or was it increasing over time? Is there a geographic region or specific facility type that's most adversely affected? That becomes important even at a national level. And then if you identify something, how do you know whether or not you made a difference if you don't know what had been happening over time? So before we dive in and try and solve this problem, I just at least want to acknowledge some challenges that affect nursing homes and in long-term care in general. For example, in the year 2013, there were over 35 million hospital discharges. And of those discharges, 22%, or 8 million inpatients, were discharged to a post-acute setting. And of those 8 million, 9% went to a skilled nursing facility. And that, if you roughly estimate, that's about 1 million. And that was in 2013. I expect that has increased over time. And why would I expect that? Well, because of the Silver Tsunami. Have anyone heard of the Silver Tsunami? Anybody? Raise your hand. All right, there's only a few people. I think the first time I mentioned it to my team, I think people thought I made that up. And I promise you, I'm not that clever. It's a term that was coined several years ago, and it's used as a metaphor to describe the growing older adult population. So over time, the older adult population is expected to continue to grow. And if you're in the baby boomer population, thank you. And, it's hard because the term tsunami almost implies that older adults are a danger or something to society. But in actuality, it has some implications. So let's talk about that. The Census Bureau estimates that in the year 2050, the population aged 65 and older is projected to be 83.7 million. That's almost double the population of 43.1 million in 2012. Also, for the first time in U.S. history, older adults are projected to outnumber children by the year 2035, and that's really not that far from now. And you see the older adults, 65 and older, are represented by the green or the teal line and bar graph, while children under 18 is represented by the orange. And you see approximately at the year 2035 where the coin flips a little bit, where older adults represent a larger proportion of the population compared to children under 18. Well, what else do we know about older adults older than 65? When the majority of long-term care residents were 65 and over in 2011 and 2012. Now, this data I acquired from the National Center for Health Statistics. It's a bit dated, but I'm pretty sure that the statistic is constant over time. And you probably all can attest to that, especially if you work in a long-term care setting. You know that most of your residents are 65 and older. But what else do we know? We know that long-term care residents have a higher risk of infection for a number of reasons. And some of them are because they have functional impairment, comorbid conditions, frequent hospitalizations, and frequent exposure to antibiotics that makes them, susceptible to particular infections as described by Dr. Pollack earlier. So why do I mention all this data? Well, all this information I provided to you is to help you understand what some of the implications are. You may have been able to hypothesize some on your own, and these are some of my hypotheses, is that as older adults increase in the population over time, and then they become more dependent upon long-term care facilities, and they already have this predisposed risk, there will be an increase in acute care, long-term care facility volumes, increase in demand on health system resources, increase in healthcare transitions as people move from the community to the hospital, or from the hospital to the nursing home, or nursing home to the hospital, so on and so forth. And all of that together can be a threat to healthcare quality, infection prevention, and control. If you think about the infrastructure that we currently have, can we handle this? Even you see people as they're admitted, the acuity of the patients or the residents themselves are increasing. So what do we do as this problem does not go away and it continues to grow? Now, when I started this section, I talked about challenges, plural, but I only mentioned one huge example. And I know that this is only one of many that you are impacted by. But I believe that the example I just provided to you perfectly illustrates how there are forces or activities external to your facility that you have no control over, but then impacts your ability to provide care for your residents. So what are some strategies to overcome the challenge? Well, first, I think we need to acknowledge that you don't work or exist in a silo. You're part of a system, and you share patients and residents with other facilities in your geographic region, and sometimes outside of your geographic regions, because people can cross state lines in order to get care. You probably know that from your own personal experience, in addition to your work experience. I know this makes me think about my grandmother. For 2 years, she was really sick, and she was admitted to at least 2 different hospitals and 3 different nursing homes over that time period. And I know for a fact that had an impact on the quality of her care, the continuity of her care, and probably led or contributed to her eventual health outcome. Therefore, it's incumbent upon healthcare facilities to implement a coordinated approach in order to improve healthcare overall. In fact, colleagues within my division conducted a study, and they looked at the interconnectedness of healthcare facilities. They used an example of an antibiotic-resistant bacteria called CRE, and they constructed this model and looked at 5 years among 10 facilities that share patients. And if you look at the gray bar, it shows the status quo, the things that typically happen in, a facility and transitions to care. If they did the status quo, then approximately 2,000 patients would get CRE. However, if there was a coordinated approach implemented where facilities talk to one another, They involve the other partners in healthcare, whether it be laboratories, radiology, whomever, and also include public health, then that number would be reduced to 400. Only 400 patients would get CRE. So the bottom line is that more patients get infections when facilities do not work together, or you flip it around and say less patients will get infections if facilities work together. They concluded their study remarks with providing a number of recommendations in order to help facilitate a coordinated approach. But one thing that's necessary and we can't escape is that facilities have to implement infection control in their own facility in order for this to work. So despite the coordination that needs to occur, there still needs to be something that's implemented at an individual level within a facility. And that's even become more apparent, and there's more attention towards that in recent years. If you just look at government and regulatory activities within recent time, focusing primarily on long-term care, ranging from the HHS National Action Plan to prevent HAIs to the CMS regulatory requirements that were finalized in 2016. Specifically, the National Action Plan to prevent HAIs, the language there states that nursing homes should be encouraged to have HAI infection surveillance and reporting to NHSN, with a goal of 5% enrolling in NHSN after 5 years following its launch, was approximately about 2017. Also, nursing homes should construct a data collection system to support assessment of healthcare quality, which includes disease surveillance, among other things. And then there's the reform requirements for long-term care that were finalized in 2016, which I'm sure you all are very familiar with. That was a phased approach, but it had a particular section entitled Infection Control, where it says that we, CMS, propose to require the facility to have written standards, policies, and procedures for the infection prevention and control program, including but not limited to a system of surveillance designed to identify possible communicable disease or infections. So why do surveillance? Surveillance is kind of the theme here, right? Dr. Pollack talked about it a little bit. So I just want to dive into it a little bit further, because you may wonder, why is surveillance mentioned as a possible solution for improving care or infection prevention programs within a facility? Well, let's talk about the term. I think that surveillance is probably a common term that we use in society, but it's often mentioned in a context of security or criminal justice type thing. Probably many of you, including myself, you have surveillance cameras outside your home or inside your home or in your business. We all understand. I mean, even if you walk down the street today, there's probably a surveillance camera that has caught you walking down the street. Well, surveillance, it allows you to know what's normal when something is no longer normal and may be a cause for emergency response. Well, public health surveillance is the same thing. The formal definition of public health surveillance is that it's an ongoing systematic collection, analysis, interpretation, and dissemination of data regarding a health-related event to reduce mortality, morbidity, and to improve health. Now, I know that's a mouthful. It's a lot to grapple with, so I'll provide an example for you all. So here I have a few headlines, and I'm sure that you have seen at least one of them this year, particularly with the measles outbreak. I think we take for granted that we, as public health, understand when an outbreak happens. It gets posted in the media and we just take it as truth and say, okay, well, there's an outbreak, there's something to worry about. But have you ever wondered, how do we even know there is an outbreak? How do we know that, E. coli is a problem? Don't people get E. coli, at least once a year, or maybe measles or something like that? Well, the answer is surveillance. It's surveillance because CDC has a systematic, ongoing data collection system for these diseases and these infections. So we know what's normal, or what's called baseline, if you heard that term before. And when things have risen to a point where there's a red flag or a cause for concern or a reason where you should implement some type of emergency response. And surveillance allows you to collect data over time, and it's the cornerstone of what we do at CDC for this reason, because it enables you to answer a number of questions, like I mentioned before, the who, what, when, where, and how. Even if you don't have the ability through your particular surveillance system to answer every single question, it at least provides you with enough signal so that you then know where to go digging and where to go looking further. And it also knows helps you know when the outbreak is over. How will we know when that measles outbreak is over? Well, again, the answer is surveillance. Well, lucky for all of us and for you, you don't have to go looking for a surveillance system. You don't have to construct something on your own within your facility because you have the National Healthcare Safety Network available to you. Although the term surveillance is not in its title, that's exactly what it is. It's a surveillance system. It's the most widely used HAI tracking system. It's web-based, as you all know, and it's a resource for healthcare facilities to collect data, not just for us at CDC, so we can provide national estimates and publish papers, but it's also available for you as a facility, as a long-term care facility or acute care facility, and even including ambulatory surgical centers where you can identify problems within your facility itself, measure progress of any prevention effort you may implement, and then, secondarily help comply with quality reporting requirements. Currently have over 22,000 facilities reporting into NHSN, and the number keeps ticking up, which makes NHSN one of the largest surveillance systems at CDC. So I won't go through this in detail because Dan had already described it, but the long-term care facility component has 3 modules, and you'll learn more about that today during the training. And you'll notice that the healthcare associated infection module only has UTI under it. And that's mainly because it's a placeholder. We expect that we will continue to grow. So in the near future, there will be additional infections added to that module. So let's talk about specifically the benefits of NHSN and how does it fill a gap? Remember the burden estimates I talked about and those limitations. Well, when you participate and you report into the respective modules, it allows you to understand the epidemiology of select infections within your facility. We also use standard infection definitions. So if you are part of a large corporation, if every facility reporting into NHSN complies with the protocols we have, you're measuring the same thing. It's not apples and oranges. We also allow you to benchmark not only at a national national level, like I mentioned earlier, but also for your facility. You know what's happening. And then again, identify prevention targets, goals, and track prevention progress. So, with that, I conclude and say, NHSN can provide the data to inform prevention because, again, it answers those questions. And that's the reason why it's the cornerstone of what we do at CDC. But, it's no use to anyone if no one's using it. So we need you. We very much appreciate you all being here. We want you to spread the word, tell your colleagues and others who work in the long-term care arena or other partners you may have about NHSN and the importance of reporting to it. And, we're very grateful for those of you who have already bought into the message that I'm giving you today. We recently ended a project called the CDI Reporting and Rejection Project, where we partner with CMS and the Quality Improvement Organizations, or QIOs, and the nursing homes they recruited. How many of you all participated in this project in one capacity or another? Thank you so much. You all have made a world of difference. You helped us not only recruit a number of nursing homes and surpass that HHS National Action Plan goal of 5%, but you also helped us accomplish the objectives of increasing enrollment, establishing a CDI baseline, and then providing you with an opportunity to monitor your prevention outcomes. Just to give an example, nursing homes enrolled in NHSN in June 2016 were kind of dispersed across the country. We didn't have a lot at the time, and this is right at the beginning of the project before recruiting really got started. We only had 334 nursing homes, representing about 2% of nursing homes in the U.S. But at the conclusion of the project in January of this year, we had so many more. There are over 3,300 nursing homes enrolled in NHSN, which represents 21% of facilities throughout the U.S. And that far exceeds the goal that was established or determined and mentioned in the HHS National Action Plans. And it's enabled us to do a lot. And you'll probably hear a little bit more about that during the training. But I'm very grateful for the work that you've committed. And we learned a lot from you, which then enabled us to make a number of improvements, even to this training where we're here today that Courtney had mentioned this morning. Well, increased participation is great, is wonderful, is necessary. But in addition to that, we also need quality data. And that's one reason that you're here today. And you'll probably hear Dr. Antilla say, garbage in, garbage out. That's her quote. She may mention that more than once during the training because it's true. If the data we have is not valid, if it's not reliable, then there's not much we can do with it. And then we're limited in our ability in order to fill those gaps in the burden estimates or those gaps in understanding what's necessary in order to build our prevention practices. So let's talk about the annual training. it's not only for us to give to you, but also for you all to give to us. And I think we all come here with our respective skills, abilities, knowledge, and subject matter expertise. And hopefully, even with my example of talking about the interconnectedness of facilities, well, there's also interconnectedness between you and I. Like, we have information that's valuable to you and so on and so forth. So it's an opportunity for us to link our arms together and really make a difference. I mean, honestly, we all came into this not because we wanted to be rich, because if that was the case, we'd probably be somewhere else, right? But we all have a heart for what we do. We want to improve healthcare quality. We want to reduce morbidity and mortality so we can make a difference for the people that we care for, and then for those in the future. I mean, one day I may need to be in a long-term care facility, so I need all of you to help me get this thing right. So this is our NHSN long-term care team. You have myself and my team, and you've already heard from a couple of us, and you'll hear from others throughout the week. I just want to at least introduce you all. I don't know if I've done this before, but so you'll know who helped organize this training, who helps provide materials for you to access online, and who also answers your questions. Sometimes the questions may be relevant to the system itself, but if it's particular to a particular protocol or a particular module, NHSN long-term care facility component, then it comes to someone on this team. And so just an overview: in the mornings, you'll receive some information about epidemiology, of course, the NHSN protocols, infection prevention. And we also have some case studies to engage you all, to make sure that you're not just passively listening, to have discussions with you so you can inform us as well. In the afternoon, we have some hands-on sessions. You'll learn more about the capabilities of NHSN. We have the tours that Courtney mentioned. Also, we have concurrent activities. So we have busy time during these 2.5 days where SAMS is here. Courtney mentioned that as well. And we have NHSN user support who will also provide some assistance. So if you have basic questions like, how do I change the user in my facility, or, my facility got bought by another company, what do I do now at NHSN? They're here to help you with that as well. And we have very special guests, the healthcare personnel safety team. They're here to talk about influenza vaccination reporting among your healthcare personnel staff. They'll give a brief presentation, but they're also located out in the lobby. They have a table where they can provide you with some information and answer your questions and help you get started, because they're actually a component of NHSN, and it's open to any facility to participate. And I think that topic is particularly relevant to long-term care because your residents are so vulnerable to influenza, and it's important for staff to be vaccinated. And also, we had the CDC store. So if you want to go back home and you want to brag and say, hey, I went to Atlanta, and not only did I go to Atlanta, I visited CDC and heard about the history of CDC and went to a tour, then you can get some branded merchandise and go brag to your friends. So that's the conclusion of my remarks. Thank you so much, and I hope you all enjoy the remainder of the training.